Deborah Thrower. She's supposed to be here, Trish. If she comes on, would you let me know? Trish?
I thought I saw her earlier. Is she on board?
She's not on mine. Yes,
Miss Deborah, you there? I can see her face.
her video's off.
I see Mr. Lemoyne. He just came on board too.
Deborah Thrower, I'm showing her video's off.
I just see her profile picture. I don't actually see her, but I see her name.
She was hooked up earlier. I don't know what happened.
Okay.
Deborah, if you can hear us, unmute your microphone. Maybe she called in.
I see 3 call-in numbers. I'm not sure who those associated with.
I'm gonna see if I'll see if I can get her. She works with me.
Oh, great. Thanks so much.
Okay.
Keith Johnson's here. Donna's here.
Yes.
Carol.
Yes.
Mia. LeMaire. Mary Jane. Angela Lee is here.
I'm here.
Great. Matt Dugas.
Here.
Clyde.
Here.
Michelle Broussard. Shannon Crumlish.
I'm here.
Thanks. Butch is on the phone. Shannon Thomas.
I'm here.
Thank you. Vicky.
I'm here.
Butch just texted here. Vicky.
I'm here.
Terrific. Burnell. Burnell. I think you're here. Someone said they.
I can see him. There he
Okay, I
is.
can hear you now.
You can hear.
Thanks. CG.
I do strange things.
Thanks, Burnell. CG Hollis.
Yes, ma'am, I'm here.
Thank you, ma'am. And Katie Landry. Katie?
I see Miss Katie.
I'm here.
Okay, thanks. Okay, call the meeting to order. The first order of business, I need a motion to approve the agenda, please.
I'll make that motion.
Okay,
Yes,
motion by Clyde. And a second,
Second, Burnell.
Brunel. All those in favor, say aye.
Aye.
Second, opposed? None. Okay, the only correction, Trish, on the agenda, it's not on the agenda itself, but it's on the explanation of the agenda online. It says appoint a secretary, and we elect officers, we don't appoint. Our next item is approval of the minutes. I need a motion to approve the minutes.
So move.
Carol?
Yes.
Carol moved to approve the minutes. Is there a second?
I'll second Katie.
Katie? All those in favor?
Aye. Aye.
Opposed? Next item is reports. Then old business. Is there any old business? Trish, I have a question under old business about
Okay.
the last meeting. I'm looking at a document that may or may not be current that shows a holding company called Life and Specialty Ventures. A subsidiary of that is Usable Life Insurance, and a subsidiary of that is Educational Benefits, Inc. So what I would like to find out, if you could find out from Shane or someone who works for EBI, is who owns 100% of EBI? Is it owned by a group? Is it owned by 2 or 3 people? Who are the owners of the company we're doing business with? Can you find that?
To my understanding is John Starling, but I'll do a double check.
I'd appreciate it very much. Thank you. New business, discussion and or action regarding the Employee Insurance Advisory Committee Secretary. Our current bylaws have Trish being the secretary, as Mona was, but Mr. Mouton requested that we have a member of the committee be a secretary. The bylaws or the explanation of this committee that the board passed did not require that Trish be the secretary. So we normally elect officers in January, but we need a secretary prior to that, according to Mr. Mouton, and we aim to please. So if someone would have a nomination, I'd appreciate it.
Nancy, I'd like to nominate C.G. Hollis, please.
C.G. Hollis is nominated. Anyone else? C.G., do you accept?
Wow. Yes, ma'am. I do. Sure.
All right. I didn't want to do this if you didn't accept. All those in favor of C.G. serving as the secretary?
Aye.
Aye.
Opposed? Thank you, C.G. And C.G., I'll give you the role in the motions up till now. And you can just follow the agenda and do general statements because we will have the recording of the meeting. So
Great.
most important of the votes.
Sounds good.
So we have Claude and Burnell making a motion, and then we have Carol and Katie making a motion, and then Katie with your nomination. Next on the agenda is a quarterly report on health plan and employee group waiver plan with Mr. Fontaine. Before he starts, I want to apologize in advance to Carol Broussard and others. I know you requested that you get your report by Friday, so you would have the weekend to look at it, especially active teachers who don't have time Monday and Tuesday. That didn't happen. We did our best. Some people got them Monday. Some people like me didn't get them at all. But hopefully we've learned about it and we're going to start a little earlier, and hopefully next time we will have them to everybody by Friday. So my apologies. Mr. Fontaine, the floor is yours.
All right. Well, good evening, everybody. I wish I was in person with y'all, but glad to see everybody on the screen here. I'm going to take you through the reporting from January through August, and we'll start obviously on our first health plan claim summary page. And you can see that from our participation numbers have not changed much, just went up slightly. Total claims are a little above 35 million. We've gotten plan reimbursements of close to 2.5 million at 2,491,250. Our retiree drug subsidies have totaled 872,507, leaving us with a net claims paid figure of 31,691,380. Our fixed cost at 2.7 million, and then of course our Humana premium at just a little over 400,000, giving us a total plan cost of 34,806,184. When we compute that on a per employee per month basis, it comes out to $754 per employee per month, or per retiree per month. And that is a 2.9% increase over 2019. And further slides and pages will explain what's going up and how the plan is performing in detail. When we look at our funding is totaled $33,248,315. And that funding obviously is a little more planned cost than there is funding. That's leaving us with a deficit, as you see at the bottom, of $1,557,869. Okay. The next page is going to help us compare more in detail on an apples to apples basis, because we do this on a per employee per month basis. So you can see that we haven't had much change in medical. Our per employee per month number is $492 as opposed to 2019 at $490. Our prescriptions at $296, actually with $1 less than 2019 at $297. total claims at the 788 versus 787. What has come down is our plan reimbursements. Last year, we had 5 rebates credited in 2019 on our pharmacy. Thus far, we've gotten 2. We're getting another one here in September. So that's just a matter of catching up on some our plan reimbursements from the standpoint of our prescription drug rebates. If you remember from previous meetings, our prescription drug rebates are going up, and that's what's holding the cost of the plan steady. Retiree drug subsidies are up. I'll remind you that our retiree drug subsidies are going to actually go away and be replaced by the Employer Group Waiver Program, or as we call that acronym, the EGWIP program. That's going to provide us an additional $2.6 million of savings projected for 2021. And that will be effective on 1/1. And we are completing the implementation process. And I can tell you, Miss Trish and Brooke have spent countless hours every week on that implementation. So all of that is running smooth. We're on track. We're on schedule for that. And once again, that's going to bring in about $2.6 million of savings during the 2021 plan year. So from a net, we know that our medical and prescription drugs are about the same. The reason our cost is up right now is I have a little less rebate from the prescription drug into the plan. That'll catch up as months go on and we get these rebate checks in. From a total fixed cost standpoint, not much of a difference there. Our retiree premium with Humana obviously went down. That's a 28.7% decrease from last year. I'll be talking to you about that renewal shortly into the presentation and have some more positive news for you there. We have another reduction in cost with our Medicare Advantage program this year. From a funding perspective, I want to spend a little time on this because there's a reason why your funding is down. If we know that your participation is up, we're covering more employees and retirees today than we were last year. If you look at the top, 5,772 is our average compared to that average last year of 5,727. That's just 0.8% difference, but it should mean more funding. The reason why we have less funding is because of the migration that we've had to the Blue Saver plan last year. That and also on a per capita basis, more singles than families that we increased on last year. Those two factors, predominantly the migration to the Blue Saver plan, has given us less funding. So we're funding less into the plan. The plan has had a slight increase in cost, and that's what produces that deficit. That should be moving towards correction in the next several months here. On page 4, this really kind of will show you the impact of the pandemic on our plan, because as you can see, the January and February claims pretty normal, March as well. Then when things should be starting to ramp up a bit in April and May, because people have met their deductible and that type of thing, and we're starting to pay a little more in claims. Actually, we saw a downturn in claims, and April came in at 2.3, and then only a 1,849,000 for May. And of course, June, kind of a normal month. July, more of a normal month. And then here comes August at $4 million of medical claims. I can tell you that is part of some pent up demand. We have a number of cancer claimants that had procedures and that type of thing. I'll share more detail with you on that, but I do see some normalization. So, for example, you've heard me mention that a normal week of claims for this plan, and I know these are high numbers, but a normal week of claims is in the $550 to $650,000 range, and then probably late July all through August and first couple of weeks in September, those numbers were basically double. We were having 7-figure weeks, which was the pent-up demand from the pandemic. And I'm so pleased to tell you that yesterday's claim run finally came back to normalization. It was about 530,000 after I'd watched 1,000,001, million, 1,000,002, that type of thing on these weeks. So we're normalizing, and I would suspect that we'll see some more favorable claims, although we do have a lot of ongoing high-cost claims with regard to cancer. And I'll share more details in that. Any questions before we go any further on just the two big summary reports here? The next page.
Can Trish open the file? Is it only me? I'm not seeing it on the screen.
I showed that it's screen sharing, but Mr. Mouton is noting that he can't see it either. So no one can see page 4?
I just
Okay.
see-
Can't see any.
all I see is your menu, but not what you're trying to open.
Okay, let's try it again. Hold on 1 second. Can y'all see page 4 now?
No.
The menu.
I'm
Mouse is not even moving on the screen for me.
I can see, it says it's screen sharing. Let me see if there's anything else, y'all. Sorry,
It's like it's frozen.
like it's frozen.
Yeah,
Mhm.
turn it off and then
Let me
turn it, yeah, and then go back. It might come back.
try it one more time.
Hush.
Glad it wasn't just me. My computer was broken.
Do you see it, Mark? What if, I can see it on my screen. Yeah, and it shows it's screen sharing.
No.
What if,
See if they can see it.
can y'all see page 4 now?
No, we see you.
Just you.
Hold on. It's showing from here that it's screen sharing.
No, controls for the meeting.
Up top. Let's see.
No,
Let's just go on. Most everybody has a
Okay.
document
Hey.
except for 4 of us.
Yeah,
you gotta pick the document.
right. Can you see it now?
There
Now,
you go.
Yes,
Yay.
indeed.
Okay, awesome.
Okay.
Thank you.
All right. Any questions on this, on the summary plan analysis before we go on to the details? Okay, let's go to page 6. Okay. From an enrollment perspective, not much of a change here, only 0.8% of increased participation from 2019. The employee-only participation increasing 1.1, employee with dependent, 0.5%. That's what I was alluding to when I told you that the funding has come down a little bit. When you measure that funding, if you have more singles participating than families, obviously that takes your funding down. But the majority of it is the enrollment. And let's go to page 7 because that gives you the details on that. So when we talked last time, we knew we had some migration from the basic plan. The basic plan lost 17 singles and 45 families. The enhanced plan gained 29 singles and 7 families. The Blue Saver plan gained 21 singles and 51 families. So that gives you a good explanation as to your funding. And I also pointed out last time, remember, we have had no premium change to this plan since 2017. And when you find plan members moving towards the enhanced plan, that tells you that they're comfortable with the premium structures on the plan, and some people are moving towards a higher benefit level.
We sure don't need a premium increase now, that's for sure.
Ma'am?
I said, we certainly don't need a premium increase in the midst of COVID, that's for sure.
I agree. That would be tough. That would be tough. But we're watching these expenses, and hopefully these ongoing large claimants will have some calming, and we get past the pandemic and the normality of a routine look at claims, because the pandemic made them go down and then makes them come back up, and then it'll settle back down to the norm. When we talk about enrollment, let's go to page 8. Membership is the number of bodies in the plan. Of course, enrollment is the number of employees and retirees. So while enrollment came up 0.8%, membership has come up 1%. Nothing to get super alarmed with right now, but I've talked about this subject a lot, and it's more important today than ever. I do suspect from looking at a number of our oil and gas service clients that we could have some continued layoffs in that industry. Hopefully things pick up in the latter part of this year in 2021, and that does not happen. But if it does happen, we could pick up some additional membership, and we're going to watch that closely, because that could help the plan. If it's healthy membership that we pick up, it can hurt the plan if we pick up some high-cost claimants. Usually when you have a plan as mature as yours is, and you have these high benefits and low cost, you've probably got the dependents in the plan that you usually are going to have on a by choice standpoint. So in many cases in that situation, we take on additional membership that can help out with funding, but not necessarily really hurt us poorly in claims. What I'm alluding to there, if somebody was looking at your plan because it was better in benefit and they would have a lower cost because they're going to be a high cost claimant, they would have made those decisions at the past open enrollment. All of this comes to a head on page 9, where we look at the fact that our spousal claims, and don't think the 5% higher is anything to be alarmed with, because many of our cases, whether it be school systems or other municipalities, have a much higher spousal claims rate, sometimes almost double what we see of the active employee or retiree. Yours on a 3-year average is only 2.3% higher, but we're watching that very, very closely. From a medical claim standpoint, very stable, increasing only 0.4%. Now, while we've only increased 0.4%, I'll tell you that the number of claimants with claims in excess of $50,000, and this is going to maybe surprise some of you, in that during the pandemic, that doesn't really slow down high-cost claimant activity. So when we compare the first 8 months of 19 to the first 8 months of 20, we've gone from 69 members having claims over 50,000 to 74. And the increase in claims on that is $2.3 million. So that's where our increase in claims came from, as purely high-cost claimants. Not all of them ongoing, but several of our high-cost cancers and circulatory claims are. So we're watching that closely as well. On a prescription drug front, on page 11, we've decreased some 3%. While prescription drug costs are rising, our high-cost medication utilization is rising because of the discounts, rebates in contractual terms that we've negotiated with our pharmacy benefit manager. We've been able to hold the cost steady on our prescription drugs, which is in this day and age doing quite well, because we're seeing on average double-digit increases on prescription drug claims, and we've been able to hold yours stable with the contractual negotiations there. So from an overall total claims perspective on page 12, total claims have remained stable, increasing less than 1%. Total paid claims net of reimbursements up 3.3 because we're waiting on some pharmacy rebates. Now on page 13, this compares enhanced, basic, and Blue Saver from not only a participation standpoint, but from a claim standpoint. So really, that's the bottom three bullets that tell the story. The enhanced plan has 15% of your participation, but at the same time, 20% of our claims. So it is not breaking even from any standpoint. The basic plan, 64% of the participation and almost 70% of the claims. And then, of course, the Blue Saver, which is now up to close to 21% of the participation, but only represents 10% of the claims. So not wanting to have that any type of rate increase right now, but if we did, we would actually weight that more on the enhanced and basic plan, because the Blue Saver is paying for itself at this particular time. Total plan cost per employee per month, again, that 2.9% that we showed on the first page. Our increases on an annual basis since 2012, averaging 2.5%. Folks, I'm going to tell you that healthcare trend during that time is it's been 6% for the last couple of years, but prior to that, it was even more. And that's just on the medical side. On the pharmacy side, that trend is low double digits, anywhere from about 12 in some plans down to about 9% now. But we fared out much better at 2.5%. By type of service on page 15, you can see that our hospital inpatient is the category that went up, and even during the pandemic. So once again, high cost claimants, once again, predominantly that cancer, where your outpatient and professional claims utilization decreased 4.3 and 6.5 respectively. Top diagnosis on an inpatient basis. Your circulatory, which is number one, it actually has come down a little bit on a per employee per month basis from 23 to 20. You'll notice that neoplasm, which is cancer, has almost doubled. $11 per employee per month last year, up to 20 currently. The other areas that have increased is injury and poisoning. I'll note that injury and poisoning is usually not an ongoing category. It's a result of a couple of high-cost injuries when I looked at that. Respiratory is going to be a function of COVID. That won't be permanent, thank God. And we had a couple of high-cost pregnancies for the perinatal period conditions. None of those categories, with the exception of the cancer, are long, ongoing claim type categories. When we look at the next page, page 17, on outpatient, it basically says the same thing. Factors influencing health, that category is a miscellaneous category defined at the bottom of the page, but it includes your maintenance chemo. So when we have a lot of activity in chemo, that will show, and that's what's jumped it to number one. And then, of course, cancer, number two, but dropping from $28 on a per employee per month basis down to that 20 per employee per month. Top facilities, not much of a change there, with the exception of Lafayette Surgical Specialty taking number 5 instead of the Heart Hospital, but Lafayette General, Lords, MD Anderson. You'll notice that MD Anderson's numbers went from 14 to 22. And when we're talking about high cost claimants, we know that care at MD Anderson, albeit they are a center of excellence, it is not inexpensive. Page 19, pleased to tell you we're constantly going up on our generic utilization percentage, and now at 88%. And that is so good, and we should maybe pat ourselves on the back a little bit for the communication and that type of thing that's going on there, because 88% for a school system is quite high. Most other systems average around the 85, 86. So very high compliant plan from your membership, albeit when we say 88% of our claims, and we turn to page 20, 88% of your claims only representing 13% of your total spend when it comes to pharmacy. And that's because of the continued increase in our high cost medications. We've also had a bit of a decrease, and this has nothing to do with COVID. We've had a bit of a decrease on our prescription drug utilization. I think that'll ramp back up. It's more seasonal than anything else. We start seeing some of the meds that we see in the fall, and all that will pick back up and come back to the norm. Our top 10 drugs by number of prescriptions on page 22. Probably the first time I report to you that it does not include a pain med, hydrocodone. If you remember from previous meetings and you look back here, hydrocodone back in 2015, pretty high on the list, stayed pretty high on the list. And then, of course, the federal government no longer allows for a 90-day script on that. And that's taken it down. And then, of course, it's been much more scrutinized as far as prescribing it because of the addiction involved and things like that, and overprescribing. So that's come down. All of the rest of these things you see here are what they're supposed to be and very common. Don't see a lot of any kind of mental and nervous medication or anything like that. So all of that looking good. On page 23, these top 10 medications are only 2.2% of your prescriptions, but almost 30% of the total prescription drug claims dollars. You see the Humira, that's also the Stelara, all of the anti-inflammatories, Consentix, Dupixent, those are all of, once again, high cost rheumatoid arthritis, plaque psoriasis, Crohn's disease meds. And then, of course, the Eliquis and Xarelto, new blood thinners that have hit the market, quite pricey. Stelara, another high cost anti-inflammatory. So your mix of high cost medications are no different than any of our other large cases. But through our contract, even though we see a 7.4% increase in high cost meds, just by measure of the top 10 here, remember your prescription drug number actually went down. So contract performing very, very well. Even with more utilization in the high cost claims area, our total spend on prescription drugs has remained stable and actually decreased. PPO savings performing very, very well at 69.6%. That's the reason that we've remained with Blue Cross, because on a carrier model, those are the highest discounts we can obtain in the marketplace right now. At the same time, network utilization remains very, very high. So we're providing your membership with not only the best discounts from the carriers, but the best choice as far as hospitals and doctors go. On page 26, our cost breakdown, 7.9%. A lot of times we've been asked in meetings like this, why aren't we just fully insured? Why are we running this partially self-funded plan? Well, in a partially self-funded plan, you gain control of your plan, where you're seeing much more reporting, and you can act accordingly to put in cost saving measures that don't necessarily hurt a member, but can reduce the cost of a medical or a prescription drug claim. At the same time, if you were fully insured, we wouldn't be talking about 8 cents on a dollar of fixed costs. We would be talking double that or more. So big difference in self-funding, and actually for your size plan to be running at 7.9% is very favorable. We've been able to keep the reinsurance costs down as well as the administrative cost from Blue. So on page 27, and remember, some of this will stabilize with the additional pharmacy rebates that we're going to get, but because of that migration to Blue Saver and the decreased funding, the plan costs net of employee contributions, because if we've got a 2.9% increase in the cost of the plan and a decrease in funding, we're at about a 4.9% increase net of employee contributions. On page 28, you can see once again, look at that area above 100,000. Now, this is measuring the first 8 months of 19 to the first 8 months of 20. And albeit we only have a 2.9% increase, and remember, as we go further into the year, whatever member hits that reinsurance, those costs won't be on the plan anymore. They'll be reimbursed to the plan from our reinsurance. But you can easily see that above 100,000, last year 24, this year 28, last year 3.7 or almost $3.8 million, this year almost $6 million, and that's a $2,129,000 or $2,130,000 difference, all from high cost claimants. Any questions on the reporting?
I have a question, Lynn. Do I understand correctly, the Blue Saver plan has increased its membership, paying for itself, but it's reduced the revenue to the overall plan? Is that correct?
Correct.
Okay, thanks.
Reason being, if we look at the cost of the three plans, obviously the Blue Saver has the lower cost of the three because it's got the lower benefit structure. And as people have migrated, if you go, obviously, let's say if the cost of the basic plan is 100 and the cost of the Blue Saver plan 75, and more people go to the $75 plan, we're saving on claims, and that's a good thing. But at the same time, we're losing some funding. We still have so much participation in the basic plan and enhanced. 80% of the group is in basic or enhanced, that those not paying for themselves, the enhanced plan doesn't have enough participation to offset that increased cost.
Thank you.
Okay. I did put the benchmarking in the back of the report. This is always something that you can refer to. I utilize this when we have conversation about additional savings. If we were to look at some benefit revisions, remember that effective July 1st, there were two small benefit revisions in the plan, whereby We increased the brand name copay on the prescription drugs and the enhanced and basic prescription drug out of pocket. We brought in Regenix, which I'm pleased to tell you we've had a good number of consults already, right at about 20, and we've actually had 6-7 procedures. So as that gains momentum, that will provide additional savings into the plan. I mentioned the Egg Whip program to you, but I'm always looking to have additional saving strategies ready to go if we need to implement that. So those will be some things that we're going to talk to at future meeting. I know Mr. Butch is not on the plan, but I also want to tell you that we're also looking into another similar benefit strategy like the Regenix, and that's used by Dr. Peter Veazey in Lafayette, and that's called Arthrex. It's very similar, but I'm doing some research on that, and I'll report my research to you at our next meeting. Other saving strategies obviously are our 2021 pricing for prescription drugs. Our rebates will be increasing. Our discounts will be increasing to the tune of about $1.1 million. And I've negotiated with RX Benefits to put that pricing into the plan effective 10/1 rather than wait till 1/1, so we can start to save some money sooner rather than later. So as things normalize, we'll keep a very close watch on the plan. Obviously, we do not like to have a deficit from a funding versus cost standpoint, and we would certainly rather be back in the surplus mode. If things normalize and we find ourselves in a continued deficit mode, that we're going to have to obviously put in some saving strategies to prohibit us from having to increase premiums. I will tell you this, though, I've done a little bit of analysis, and I just wanted, not that I'm saying that we have to implement this today, but if we did do some type of premium, I just want to let you know where those figures might be. A 3% increase to the enhanced and basic plan changes the basic plan $5 a month to the employee, changes the enhanced plan $7 a month to the employee, all the way up to basic 2+ or family coverage would be a $19 increase, enhanced $22. So that type of,
can you repeat that again, ma'am?
So on the basic plan, if we were to do a 3% across the board for enhanced and basics premiums would increase $5 on single, $13 on +1, and $19 on +2. The enhanced plan would increase $7 on single, $15 on +1, and $22 on +2. Now you remember, those are gross numbers, and premiums are taken out before taxes, so the net effect of an employee or retiree's check would not be that much. It would be probably on a single $2-3 less, on the family $3-4 less, because it's pre-taxed. That increase generates about $1.5 million a year. I'm just sharing those figures because a lot of times when we think rate increase, we think of numbers that are going to, break the bank in it. And because we're only looking at a small increase right now, and because we keep utilizing cost-saving strategies that don't cut deeply into the employee or retiree's benefits, we've been able to hold all of this steady since 2017, and that game plan is not changing.
So you're not recommending now an increase, a premium increase?
Not
Because
at
it
this
doesn't say
particular
$22
time.
may not sound like a lot, but we have employees whose spouses have lost jobs because of COVID. And I mean, it's a very bad time for anybody to have an increase, even if it's $22. But on another note, you and I had spoken earlier about your summary sheet. For example, where it says average spousal medical claims per member 5% higher. That, if you just look at the summary sheet, it seems like that might be a bad thing. But as you pointed out, that is lower than the norm. Is there any way you can indicate for us?
So at our next meeting, what Miss Nancy is talking about, she was, we actually were talking, the mailman came to her house twice today, and and even though it was priority mail and she was supposed to get it yesterday, she still doesn't have her report. So when she was looking at it from the electronic copy, she noticed that inpatient hospitalization went up 16%, and that's certainly a pretty high percentage. I will provide some color to those statements in the next report, so nobody has a wow moment when they read these things, because inpatient hospitalization utilization is going to fluctuate depending on the number of high-cost claimants. It's not something that stays stable. It can go up 50%, it can go down 50% in any quarter, and your spousal increasing 5% is just because of two high-cost claimants, of which neither one of them are ongoing. So when I put these statements into the summary and y'all refer back to it, I'm going to add some additional verbiage or language to this, so you have a better explanation as to the ups and downs of these different percentages.
Yes, just
All in all,
what the
if we
norm
would-
is. Two is helpful. For example, the 89% in generic usage is above we're doing better than average. And I think that's important for all of us to know.
Right.
Nancy, can I say something?
Sure, Carol.
To retirees, they can't take another increase in benefits. I think many of them would rather take the hit and having the health plan cost go up a little rather than increasing those benefits. Not increasing, but you're getting less for your bucks.
Understand.
Wasn't any looking at increasing a deductible or anything like that. There's going to be some saving solutions on the pharmacy side from that contract negotiation. So if we talk about the basic message right now, we've endured the pandemic. We have had a higher cost year from a high cost claimant standpoint. With normalization after post stay at home order, we should see our costs stabilize a bit, and that will give us a much clearer view of where we stand from a funding versus plan cost standpoint. And should we have to bring in some more cost control measures, I'm going to do everything I can to keep those cost control measures from altering a benefit or altering a premium. But I still am going to tell you, if we were to have a high increase of claims from a high cost claimant standpoint or utilization standpoint, at some point we're going to run out of steam with cost saving solutions and have to do something mildly in premium. And I don't want to tell anybody that rates are never going to change, so I did want to at least share what a mild rate increase would look like. Not recommending it today, but we've got to get a clear picture of what these costs are going to be in coming weeks. If these coming weeks stay where they were on our claims run yesterday, we'll be in good shape. If they go back to being $1 million a week, we've got work to do.
Can you give us the numbers for a 2% increase as well next time, Lynn?
Sure.
Okay, thanks.
I also had modeled it with a 5% increase on the enhanced plan only. That would be if we just saw claims on enhanced going through the roof on us, which, you know, enhances the plan that would probably need an increase more than any other.
Any questions? Okay, next item on the agenda, or part of your presentation, is the Egg Whip program. There were some questions about that last time.
During presentation, I brought you up to speed on that. We're still in the implementation stage of that. Everything going according to schedule, according to plan. Very minimal disruption we're looking at there, that being effective 1/1. And our original savings numbers, if we would have implemented it in the middle of the year, which we didn't have time to do that. And thank God we didn't, with all of the things that have happened in the beginning of this year. But those savings have increased from the projected six to 800,000 a year to $2.6 million a year, which is very, very favorable.
Could you explain what
I'll
the
still
minimum
on
disruption is? Could you explain what the minimum disruption is?
Disruption would be the same thing as what we've talked about in the past when we put in any of our pharmacy management rule changes or anything like that. And that's the number of plan members that might have to change a script or anything like that. And at this time, it's a very, very low percentage, in the same ranges of what we talked about in the past.
So 1%, 2%?
That's not finalized yet, but in that area, 1-2%. Yes,
Okay.
Nancy.
Yes, Katie.
Lynn, I have a question. How does that program affect retirees that are not on Medicare or not eligible for Medicare?
Not at all.
Thank you.
One other item, Trish, is this on agenda? Do you want me to mention this Medicare Advantage renewal?
Yes, it's on the agenda.
Yes.
Now. Mm-hmm.
Okay. Was that up next?
Yes, sir.
Oh, okay.
Yes.
That worked out good. Medicare Advantage renewal, obviously each and every year we're going to go to the marketplace, that marketplace for your plan in our area to provide a group retiree Medicare Advantage plan that provides an open network whereby you can go to any provider that accepts Medicare. Your market is Aetna, Blue, Humana, and United Healthcare. Blue provided a proposal at $65,940 a month. You're currently paying $50,879 a month, and I'm getting ready to deliver you a rate decrease. So Blue was not very competitive. Actually, United Healthcare offered a competitive proposal. We were able to negotiate with Humana and bring them down. They originally had proposed a 3.8% rate decrease, which would decrease our rate from $242.28 per member per month to $232, taking the total premium down. And currently you have 210 members in your Medicare Advantage plan. That would have brought your $50,879 down to $48,920. We were able to negotiate the 3.8 down to 6.8, which brings the premium down to $47,433. So I'm pleased to tell you that your Humana Medicare Advantage renewal There's a 6.8% rate decrease with no changes in benefits.
That's interesting. Good news.
Yeah.
Well, what's happening there, because I know many of you are probably scratching your head and saying, how is that happening and how is that going down? Just as we negotiate better terms on our prescription drug cost, so does these carriers. They've also increased their STARS rating, and when you increase your STARS rating from Center for Medicare, CMS, you get a larger reimbursement, which helps them out and reduces their rate. So we've seen the big rate reduction last year of the 28% is because they no longer had some of the Affordable Care Act costs that they've had in the past, and their STARS rating went up, and that's continued with the STARS rating for this year. So pleased to tell you about the rate decrease there with once again, no changes in benefits.
Thank you very much. Anyone have any questions for Lynn before he goes?
Yeah, Lynn, what's the participation rate in that Humana plan? Has it increased at all?
It did increase last year, but if there's anything that we really need to communicate on at open enrollment about the plan, and obviously anything else that you folks would want to stress on, we certainly will cover. But we want to make sure we do a good job of educating, because I just saw so much with, I just went through a process here in Terrebonne Parish. They did not have a Medicare Advantage plan. Insurance and Advisory Committee, totally against it in the past. Finally, was willing to take a look at it. And once the retirees, and boy, they did some homework and looked at it very, very hard. Once they realized that this is not the same as what they see on the street and what they see on commercials, a group Medicare Advantage plan with an open network means you can go to any doctor or hospital or provider that accepts Medicare. So network's just as strong, if not stronger. And then from a benefit perspective, when it's all zero copays all across the board, it's the same coverage as you have now, probably a little better. So if you can have your choice of doctors, superior coverage, and it costs less, they got a unanimous vote. Difference is they are putting all of their retirees. You have done it on a by choice basis. I think with some education, you're going to have some folks that might want to migrate to that benefit. I know membership loves Blue Cross. I'm not saying Blue Cross is not the way to go, and I'm not promoting Humana. I'm promoting folks take a good look at and educate themselves to the benefits and the premiums and the networks, because those are the three pillars that you would make that choice upon. And at the same time, when we look at the three choices of plans, enhanced, basic, and high deductible, or Blue Saver, if you're very, very healthy and you're willing to manage your health care costs some, I think the Blue Saver should probably take on some more participation. We had good migration to it last year. Surprised me a little bit with the migration to the enhanced plan, but just want to make sure that we concentrate some good education in that area.
Before you leave, Lynn, we need you to give us the date for the next meeting. What month do you need?
What are we doing in terms of education?
That's all done through open enrollment, and we'll help you there and provide some communication on that. But the communication last year was pretty good in that, and that's why you saw that increase in participation. I think there might be a bit of a domino effect in that, and that you're going to have the best communication is the grapevine. And if your school system's the same as school systems that I've always represented, nothing beats the grapevine. the more folks that tell people that they've had a good experience in either one, a Blue Saver plan or a Medicare Advantage plan, more folks that are going to migrate to it. But we've done a good job in providing some communication in that area, and we'll beef up on that as well. And Trish and Brooke and I will work on that.
Date of the next meeting, please, Lynn.
Okay. I think it might be prudent to have another meeting before the end of the year so that at least I can report to you where we find the normalization of this plan experience. So
What do you prefer, November or December?
I would prefer November.
Okay. Tuesdays in November, select one.
Not election day.
Not election day. I was thinking the same thing. Probably the latter part. I don't know where Thanksgiving falls this year.
Thanksgiving's on the 26th.
Okay. So preferably, what about the 16th?
The 16th, we're going to run into the same problem as we ran into today. If I try to get October data all into that report and mail it out to everybody so they have it in their hands prior to this meeting.
Well, the 24th is the Tuesday before Thanksgiving. I just don't know that you're going to have the participation you want. We can try it, but if we don't have a quorum, we don't have a meeting.
And people are going to be taking off and whatnot. What about the Tuesday after Thanksgiving?
Which is December 1st?
Yes, ma'am.
Anybody have a problem with December 1st?
Nope.
I'm good.
Okay.
I'm good.
Next meeting
That
will be
gives us
December.
ample time to get the reporting in, get it mailed out to everyone. If we have some additional strategies that we might want to implement, I can get those in there as well too.
Okay, you're welcome to stay with us, but I know it's been a long day, so thank you very much. We still have more agenda. Update on bylaw committee.
Thank you so much. Y'all have a great evening.
Thanks, Lynn.
Bye.
Yes, we are working on the bylaws and hope to have something to the committee at the next meeting.
Thank you, Katie. Open enrollment, Trish?
Miss Nancy, can I ask a follow-up question to the bylaws real quick?
Sure.
So if the bylaws are not updated, is the committee still following the BBC with regard to the changes that were made in July?
Good question.
No, I think Mr. Santani had said, if you're talking about the policy change,
Right, in July.
no, we aren't until we amend the bylaws, which we're doing. We appointed a bylaw committee, and they hope to have something back next month.
Okay, so let me just pose a question. Let's just say there becomes a vacancy. So you're going to follow the old bylaws, the current bylaws in place? Because that was a question to Mr. Santini.
No, what the board did are not bylaws, but
Right.
no, I've already told Mr. Santani, spoken with Ms. Santani, if we have another opening, we'll follow the procedure that the board approved.
Okay, per BBC? Okay,
Correct.
I appreciate it. Thank you.
Thanks. Your open enrollment report?
Okay, so let's see. We have started open enrollment. It began on September 14th. It will end on November 13th. We've got numerous forms of communication going out to the employees, everything from J-call messages to emails. We've updated the LPSS website. EBI is also communicating via text messages. We've got videos that are being offered. We've got a lot of different resources. Hopefully, one of those resources will be valuable to the employee that would allow them to make any changes that they need to make for either voluntary benefits or health insurance. So essentially, health insurance is managed by LPSS Insurance, and EBI is managing all the voluntary benefits. There are two ways to connect with the EBI representative. They're offering either a phone or video conference, or the member can also use an online self-enrollment with a real-time chat option should they have any problems when they're trying to do the self-enrollment. EBI has provided us with a great video as a resource for employees so that they can take a look at their benefit options, and it gives them the know of what to do during open enrollment. We're going to conclude open enrollment November 13th at close of business on 4:30. And so far, so good. It's going well. We're giving them weekly updates and trying to communicate on an ongoing basis so everyone's aware.
Got any questions for Trish?
I have to say what Trish showed, this is Donna. It's very informative. What she put, the messages we get as a school board employee, it's good what you have. Because that was my worry with this quarantine, how that was going to be handled. So I think she did a great job.
Well,
Thanks so much, Donna.
Mm-hmm.
Thank you.
Last item is review of contracts.
I did find, I have to say, I did mine all electronically, and it was really smooth and easy. And, you know, so I want to compliment Trish on that too. I know we're trying to keep people socially distant, so it was good to have an easy way to do some of those changes electronically.
I agree. Very nice. Thank you very much for that option.
Great. I'm going to pass those kudos on to EBI because they put all that together. They did a really good job with making it easy for the
Didn't you
open
survey our employees last year, and the majority did not want to self-enroll? Yeah.
Yes, ma'am.
I understand COVID. I'm just
COVID changed all that for this year.
All right, next item, contracts and services.
There's really only been 2 changes to the contract information. The prescription care management was just on a self-renewal just because we didn't make any changes or stop the contract. It now has a end date of 8/31/21. So that one was just more or less an auto renewal. And the additional contract was the wellness. We continue with Lafayette General Medical Center. They're still going out to every LPSS location, adhering to the social distancing standards that they've set by the district. They're going to give the employees their physicals and help them stay healthy.
Well, I want to sign up for that.
I know, me too. Sorry.
In that one.
So it's been a great partnership with Lafayette General Medical Center, and we're going to continue under that contract till 7/31/21, and hopefully it will continue thereafter. We'll take a look at it again later on. And those are really our only 2 changes. It's going to offer a great benefit for the employees so they can keep up to date with their lab work and get their physicals. That way they stay healthy.
The only question I have is on EBI.
Okay.
I'm looking at the contract, and it does not say what your document says it says. You say it says option to renew every year with 3 remaining 1-year options without an RFP process. That's nowhere in the contract amendment that I'm looking at.
I'll have to pull it, Ms. Nancy. I pulled everything with regard to it and made that annotation with regard to no RFP. There's not an RFP for the 3 years, but I'll get the statements for you.
Yeah. You're saying that is correct?
That is correct. Yeah, there's not an RFP for 3 years. I'll have to pull some research
because I'm looking at
for
the
you.
amendment that was signed by John Starling and Ms. Trosclair, and with Brett as president, and it's not in the contract amendment.
I'll have to pull it and take a look at it, but everything that was made as an annotation was based on that information. But I'll take a look at it for you.
Appreciate it. Just let me know.
Yeah.
Thanks.
You're just
Anybody?
specific to EBI. You're just asking about their information?
Yes, I'm asking about your EBI document explanation says it's 1-year options without an RFP process, and RFP isn't mentioned anywhere in their contract amendment.
Okay, I'll do a double check for you.
Thanks. Any comments or questions?
Yeah, Trish, this is Katie Landry. I do have a question. One of the reasons why this is on the agenda at every meeting is to make sure that we're being informed if there are any problems with any of the contracts or the entities that we have contracts with. Are there any problems with any of our contracts dealing with insurance at this point?
No, ma'am. No, there's not any issues with any of those that are listed.
Thank you. Or any of the others?
No, or any of the others. Everything that's listed, there's not any issues, current concerns.
Okay, thank you so much.
You're welcome.
Any other comments? Thank you, everyone, for attending. I still have as absent Mia and I think two others. Michelle Broussard, and my memory's failing me, but I'll send them to
If you're
CG.
thinking Deborah Thrower, I got a hold of her on the phone and she could hear at one point, then couldn't see at one point, so I'm not sure, she just couldn't participate. I'll check with her tomorrow.
Okay, thank you.
Move that we
And our
adjourn
next
this
meeting
meeting.
is December 1st. Thank you, everybody.
I move that we adjourn this meeting.
Thank you,
second.
Clyde. Is there a second?
I second Shannon Crumlish.
Shannon, thank you, Shannon. All those in favor?
Aye.
Aye.
Opposed? Thank you. And CG, I'll get the early part of the meeting minutes to you.
Wonderful.
Have a good
Thank you.
night.
Thanks so much.
Good evening.
Good night, guys.
Good night, Clyde.
Good night, everybody.